First of all, I want to express about my pleasure that I have the opportunity to participate in your conference. My topic is study of fluorocholine kinetic in patients with prostate cancer, primary tumor and recurrent tumor. Our purpose in this study actually to evaluate the impact of quantitative parameter in differentiation between normal tissue and tumor tissue. Also to investigate the impact of tumor localization, namely local recurrence, also lymph node recurrence on the quantitative parameter. I would like to start with overview about prostate cancer. As you know, prostate cancer is the most cancer in males, and also this cancer can invade locally and also can spread to regional lymph node, also to distant lymph node. And the question how to detect the cancer on time. There is many diagnostic tools actually that can be applied in tumor detection and follow-up after treatment. For example, magnetic resonance imaging, especially T-weighted, can be applied as initial diagnostic tool. And also dynamic contrast enhanced imaging can be also has been introduced to achieve more accuracy in tumor localization within the prostate gland. Also, furthermore, tumor tissue demonstrate high level of choline because citrate metabolism is shifted to oxidation. Thus, tumor tissue demonstrate high level of choline, simultaneously low level of citrate. Therefore, we can use citrate-choline ratio actually can be applied in tumor detection. Usually spectroscopy that can provide metabolic information about prostate gland. And this imaging demonstrates actually the role of MRI in tumor detection. Here we see prostate tumor with low intensity with T2-weighted MRI, and here spectroscopy with high choline peak with metabolic map, and here we see dynamic contrast enhanced imaging. In pathology, we see correspondence between all findings. And also rectal ultrasound can be applied also in tumor detection, especially to people guided biopsy. We can also use contrast enhanced ultrasound. And here we see tumor. And now, but the differentiation between recurrence also and normal and post-treatment change is actually problematic with conventional method. A base of prostate-specific antigen has wide acceptance in tumor detection and follow-up after treatment, but with low specificity and sensitivity. Thus, there is a need of new method. As you know, that the most known metabolism or alteration of energy in tumor cells is actually increased glycolysis. Therefore, FDK is actually effective in wide variety of tumor, but his role is actually limited in prostate cancer because of low uptake in prostate, furthermore because of high accumulation in urine that can induce prostate interpretation. But there is need of new tracer. It has been demonstrated that there is high level of cholinesterase in tumor tissue that provide further support to use choline-labeled tracer in tumor detection. And for example, we can use carbo-11 in tumor detection, but its application is actually limited in PET centers that have on-site cyclotron because of low half-life, 20 minutes. Therefore, our choice is actually FDK or FECH, low-acetylcholine with half-life 110 minutes. That the imaging demonstrates that is of biopsy compared prostate cancer, and here we see FECH, the tumor is detectable actually, and here FDK, the tumor is not detectable from the same patient. And this case demonstrates the ability of FECH in accurate localization within the prostate. And here we see abnormal uptake, and here location of that uptake is right apical part. And here that is the apical slice in histopathology, and the market region demonstrate the maximum tumor infiltration we see, which correlates clearly with the abnormal uptake. And now, how to do kinetic modeling of the FECH. It has been demonstrated that phosphonium analog of choline can be observed non-invasively by means of nuclear magnetic resonance, even after its incorporation into phosphorylated choline. And how to do the kinetic modeling by means of PET acquisition. And actually, PET acquisition have many features that enable us to do kinetic modeling. First, the ability to perform accurate attenuation correction that make it possible to relate the measured count rate with the absolute tracer concentration. Also, sequential image can be acquired, that enabling the change in the tracer to be modeled. And now, PET acquisition is actually summarized as few characteristic curves, but without specific information. To gain more specific information, we need to know how the tissue responds to the tracer, independent of how the tracer was administered. Therefore, we need to determine so-called impulse response function that by measured output and input function. And output we can determine from the PET acquisition. Input, theoretically, we should make serial plot sample, but also we can do that by volume of interest on the large arterial vessel, and that is to simplify the kinetic modeling. The physiological system is described actually by decomposition of into number of interacting subsystems called compartment. As you know, compartment should not be understood as physical volume, but rather than as mass of well-mixed homogeneous material that behaves uniformly. That is the pattern of two compartments here, blood, and here we assume that tissue, and here we assume that the K1 represents incorporation from the blood into the tissue, and also K2 is returned to the blood, and K3 metabolism of the tracer, which is incorporated to cell, and CAF for represents the return to untroubled situation. The PET acquisition represents actually the summary of contribution from all compartments. Therefore, when I attempt to determine many number of parameters from such data, the resulting parameters, the variance of resulting parameters tend to be too high for reliable interpretation. Therefore, two-compartment model has been selected in our study. And that is two-compartment model, and here blood and the cell it will be incorporated to cell findings of transport system, and then it will be converted into phosphoryl choline, and it will be then integrated into phosphatidylcholine. For example, phosphatidylcholine is the main component of the cellular membrane. And that is our study, 39 patients with prostate cancer, lymph node metastasis, and local recurrence, primary tumor, neurotumor. Our study consists of two parts, 10 minutes dynamic study, and the evaluation of dynamic study was using BMOD program. That is at the beginning of dynamic study. Here we see common iliac artery, and here after 10 minutes, and the evaluation was using voice, volume of interest over the input function was created by voice over the common iliac artery, and output function was created using voice over the tumor. And furthermore, we have also SUV to make further quantitative evaluation. That is from static evaluation after about 1 hour. And to achieve more verification of our PET findings, we have compared with another diagnostic tool. And here we see prostate tumor with low intensity into weighted MRI, and here high accumulation in our PET findings. And the diagnosis of malignant lymph node was based on visual assessment of focal increase uptake corresponding with CT imaging. And our result is we see you see here significant difference between the normal tissue and tumor tissue, especially in Cowan, also in influx, of course, in SUV, and we see also the difference in kinetic behavior of the tracer in the lymph node recurrence and local recurrence. What means that actually the transport system in tumor cell is actually activated in evidence of increased power. Also, we see that kinetic behavior of the tracer differ in the force of local recurrence and also in lymph node recurrence. That can be that means maybe the kinetic behavior of the tracer depends of the tumor location. And also we don't find significant difference in T3. And as you know, T3, we suppose that T3 represents the phosphorylation of choline. That can be understood that there is no significant difference in choline phosphorylation in tumor tissue. But considering the result, the study which is titled under alteration of choline metabolism, which is performed in the ovarian cell. And in this experiment, the scintillation, the counts has been obtained after 1 hour cellular incubation with choline level, and in this study it has been demonstrated that whereas after short time cellular incubation, the internalization was essentially dependent on choline transport, and after longer time, more than 20 minutes, choline phosphorylation became the main step in cellular enrichment. Therefore, we suppose that we could find significant difference, especially in T3, when we prolong our dynamic study period. And that's why, and thank you very much indeed for your listening.
Thanks very much. Any questions?
Sorry. You're looking on my head there. I have no experience with staging, I really admit. I was interested in, do you have any false negatives? Because you said there were 4 normal studies. Do they possibly confirm to be normal on MRI or biopsy?
50% of the patient was confirmed with biopsy. And another patient, we have correlation, we have made correlation with another diagnostic tools, for example, MRI.